Thank you, Preeti, for the short introduction. And I will be talking in brief. There will be a lot of overlap between the speakers because of the importance given to one particular portion, which is the mimickers and the common pattern that we see usually. There is no financial disclosure. I like to acknowledge my two mentors over here for all what they have taught me in learning how to approach to an optic disc atrophy. Now coming to it, first of all, what is a normal optic disc, why it is in pinkish red and the other is chalky white or pale disc. This is because the optic nerve, the axons of the ganglion cell act as an optic fiber cable. It has a property. So what it does is it transmits the color of the pial capillaries. That's why you see the optic nerve head as pinkish red in color. The same thing what happens in a optic disc pallor is those axons get replaced with the glial cells and that are represented as a white cells. Okay, that's why you see as a pale. So let's keep this in mind, and as Dr. Virendra sir has already described in detail what are the mimickers that we need to look into, I'll just again what you need to remember is young infants in kids. What you can also see is when you see a normal disc, you feel that it is a pallor. So just remember that. Rest all, I think he has extensively covered it. And coming to the cause, it's always good that we have a mnemonic to just keep in back of our head. It's the icing. It's nothing but ischemia, compressed nerve, infectious or para-infectious, neuritis, glaucoma, and yes, trauma. Okay, never forget trauma. You have traumatic optic neuropathy, which and at the end will develop into an optic atrophy. Okay, so now whenever we talk about what is optic disc pallor, why it happens, what we need to remember is it's actually a degeneration. It's degeneration of the second order neuron, which starts from which is the ganglion cells, okay, which is the ganglion cell fiber. So the lesion can start from anywhere. It starts from the retina till the LGB, till the lateral geniculate body. If you have any lesion from anywhere, you will see an optic disc pallor. So what you need to remember is that if there is a retinal lesion, what we has already said, you will have a presentation which we say it as a consecutive optic atrophy. We'll come to it in the subsequent slide. But what you also need to remember is sometimes what you see as a unilateral disc atrophy, it can be an early presentation of a bilateral disease. Okay. So an approach, my slides over here is just on clinical approach because investigation and management and how to look forward is in the subsequent talks. I think Preeti is covering about it in her case series, in the interesting cases part. So in the approach, what you need to see is how to assess the optic nerve function, which we have already discussed. How to look at the disc, what are the things that we need to look in the disc, and definitely we need to examine the fellow eye. Okay. Now coming to the disc examination, these are the certain points that you like to stress on. First, you need to understand what is the type of pallor. Second is the pattern. You need to examine the nerve fiber layer. You need to see whether there is any disc collaterals, any presence or absence of it. You need to look at the cupping because sometimes glaucomatous cupping can also mimic as a optic atrophy. And you need to see the rest of the fundus. So coming one by one to each of these things. So type of pallor. So very classically in all our we have learned over the periods that we differentiate pallor into as primary, secondary and consecutive. But how to differentiate one from the other? Well, primary is the optic nerve fibers degenerate and replaced with the glial cells. Okay, and there is no architecture alteration. So what you get over here is a chalky white pallor. Okay, the disc margins are very clearly demarcated and you see a chalky white pallor. Okay, as compared to consecutive, what happens is in consecutive there is a marked degeneration as compared to what you see in the primary. So what you see a reactive gliosis. Okay, if you can see here, it is a dull white in color. Okay, as compared to what you see in the primary, which is chalky white, and the secondary, the disc margins are indistinct. Okay, so because the architecture alteration happens. Okay, so this is how you differentiate into primary, secondary and consecutive. Now coming to the pattern is either a diffuse pallor in which you see the pallor which is there throughout or you see as a segment in which half the portion of the optic disc is pale and the half the portion is healthy. So we'll come to each one by one, and I'm coming to the altitudinal pallor, which is type of a segmental pallor. Okay, so what you see over here is a sharp demarcation between a normal and a pale area. If you can look over here, you can clearly see that this is a pale area and this is the healthy optic disc. Okay, so this can be well seen in a red free filter. So what this indicates, so if you see something like this, so it usually indicates that clear-cut demarcation is because of a vascular cause. So what are the other hints that you need to look at? You need to look at the vascular attenuation if it is there at the disc margin. Okay, if you see a vascular attenuation at the disc margin, it's most probably it is because of the arthritic cause, a ischemic cause, a non-arthritic or an arthritic, and you need to examine the fellow eye to see whether the optic disc and the cup is small or there is an absent physiological cup. Okay. The second type of segmental pallor that we usually see is a temporal pallor, which is more commonly seen when there is a damage to the papillo-macular bundle, which is typically seen in case of optic neuritis. But you need to always keep in back of your mind that sometimes what you see as a unilateral disc pallor, it can be a bilateral toxic nutritional and hereditary optic neuropathies, which very classically describe in case of Leber's hereditary optic neuropathy. Okay. The third pattern what you see in a segmental optic atrophy is a bow tie atrophy. Bow tie atrophy is nothing but it just indicates that the nasal fibers is lost. Okay, so when you compare the nasal fibers and the temporal fiber and you find that both are looking nearly the same, that's what is the clinical description of a bow tie atrophy. Okay, so what you see, you can see is as an optic chiasm in which in both the eyes, if you see, so anything beyond the optic chiasm, you will have a bilateral representation. So if you see in both the eyes a bow tie kind of pattern, so that indicates that it's an optic chiasm lesion, because nasal fibers, if it is lost, so it will represent in the visual field as a temporal visual field defects. Okay, so that you will see as a bilateral bow tie pattern. If you see, then it is an optic chiasm. But if you see a temporal disc pallor in one eye and a bow tie atrophy in the other eye, so that means the eye having a bow tie atrophy, there is a contralateral optic tract lesion. Okay, I hope you just got what I said. Okay, now the third point in the evaluation that you like to see is an optic nerve fiber defect. It is best visualized under a red free filter. What you need to remember is you need to see the brightness, you need to see the striations, the visibility of the peripapillary blood vessels, and whether it's a segmental nerve fiber loss or it's a diffuse loss. Okay, as you see over here, it's a normal RNFL in which you can clearly see the striations. Okay, this is known as the bright spot, the dark spot, and the bright spot. As comparatively, since the temporal fibers are lesser as compared to the other part of the optic fibers, optic nerve, what you will see is relatively it is little darker as compared to the superior and inferior portion. But if there is a defect, what you see is there is a gap. Okay, there is a dark pattern which you usually see. So this is known as the wedge defect. This is the localized segmental loss of the optic nerve fiber. Okay, the fourth point that you like to see in case of an optic atrophy, you need to see whether there is any presence of vascular collaterals. Okay, the vascular collaterals can be of two types. It can be an opto-ciliary shunt or a disc vascular collaterals. Okay, if you see an opto-ciliary shunt, it is nothing. It's just like the blood is not able to pass through the central retinal vein, so it tries to divert the blood to some other part. Okay, so opto-ciliary shunt, the blood drives, it's not able to travel through the central retinal vein, so it goes through the choroidal circulation. So this opens up. These collaterals, they open up. So as you can see in this, you can see two collaterals. Okay, so how to identify it? You just look at the vessel. Once you try to trace the vessel beyond the optic disc, and suddenly it disappears. So this is opto-ciliary shunt. Okay, this is seen in cases of chronic optic nerve compression. You see in cases of optic nerve meningioma more commonly, a CRVO, and an optic nerve gliomas very rarely. So this is just an example. This is an optic disc edema, but I just wanted to show an example of disc collaterals, how they look like. Okay, so the fourth point that you like to see is a cupping. Okay, but how to differentiate glaucomatous cupping from a neurological disorder is you look at the neuroretinal rim. If it is pinkish in color, it's more likely to be a glaucomatous reason rather than a neurological, because neurological, the neuroretinal rim looks pale. Okay, the causes for an optic disc cupping with neurological cause is AIONs, and in case of toxic methyl alcohol amblyopia. Okay, always remember to not only focus yourself on only on the optic disc, look at the rest of the fundus to see whether you have any other signs which can explain you the cause for the optic atrophy. Like in this case, if you see in the left side, you see a metallic sheen, and when you look in the periphery, you see the bony specules. So either you see a bony specules or macular exudates or a pan-retinal photocoagulation. These are all the reasons which will give you, like the one that I am seeing over here is a consecutive optic atrophy rather than anything else. Okay, then coming to the fellow eye. So if you see an optic atrophy in one eye and the fellow eye is normal, so based on that you can think, okay, so if it is diffuse unilateral optic atrophy, you need to again reevaluate all the signs for the unilateral disc atrophy and come to the fellow eye examination. So either you see as a normal disc, or you see a small disc or a cup, which gives you a hint that whatever you are seeing, it might be an NAION, or you see a segmental disc atrophy, which I have already said, like one eye having bow tie atrophy and the other eye having a temporal disc atrophy, then it's a optic tract lesion, or if it also has a bow tie atrophy, then it is an optic chiasm. You look at the rest of the fundus examination, and if you see a disc edema, so it can be a Foster-Kennedy syndrome. Okay, you need to do a scan just to see if there is any frontal lobe lesion. So coming to the approach, first assess what is the residual optic nerve function of that particular eye. Look at the color, look at the type, look at the pattern, assess the nerve fiber layer, look for other signs like collaterals, cupping, any shunts, vessel which you can see. Don't forget to examine the rest of the fundus and the fellow eye evaluation that needs to be done. But whenever you are in doubt and you're not able to come to a conclusion, it's always best, like even if you see a unilateral disc atrophy, you should do an imaging, because you don't know, something might be sitting up inside. So I'd like to thank you for that, your patience, and it's what you need to remember, it's not about the disease what has been manifested, it is the cause that we need to find out so that subsequently we can treat him for it. Okay, thank you.